Hi, everyone. I'm Joanna. I'm a member of the SIR Resident and Fellow section. Thank you for joining our webinar tonight, brought to you by our very own pain service line. Before we begin, we encourage you to join the Resident and Fellow section of SIR if you haven't already joined, and check out our website at rfs.sirweb.org. You'll find a lot of interesting articles, educational resources, information about the different service lines and different projects that we're doing. So without further ado, I'm going to pass it off to our host tonight, who's Deshant. He's a member of our pain service line, and I'll leave him to introduce our speaker for tonight.
Thank you, Joanna, and thank you to everyone who's attended and who's on the call tonight. I really appreciate you guys taking not only time out of your busy schedule, but out of your limited free time that you get outside of residency to join in. Tonight we'll be listening on a talk about advanced interventional treatments for cancer pain, and it's going to be delivered by Dr. Hemant Kalia. So Dr. Kalia has been very kind enough to lend his time. He is an interventional pain and cancer rehabilitation specialist. Following completion of his fellowship at the University of Rochester, Dr. Kalia recently started up his own pain clinic and pain practice at Unity Healthcare Systems in Rochester. He has a particular interest in cancer pain management in addition to other pain conditions. And without further ado, I'll turn the floor over to Dr. Kalia. Thank you again for attending, and enjoy the show.
Thank you, Deshant. I really appreciate. I'm glad to be here and giving you this talk, and thank you everyone who's joined in to listen to this talk through their laptops, their cell phones. The talk today, the learning objectives will be kind of broad. They will be. I'll be spending a little bit of time about discussing the basic pathophysiology of cancer pain and why it's a challenge to manage, and what's the conundrum behind different treatment modalities. And then we'll delve into some of the new advanced treatments, some highly advanced treatments which are available and are coming up over the course of the last 5 to 7 years. And please feel free to, if you have any questions during the talk, please feel free to, text or in the chat box. You can tell Deshant, and maybe I'm not sure if you can directly, I can hear you or not, but you can send your questions directly to Deshant, and I'll be more than happy to take questions during the presentation. All right, so having said that, we'll going to start with the cancer pain. Now, cancer pain is a really challenging foray. If you talk about different causes of cancer pain, they can be broadly distinguished into either secondary to the mass effect or the tumor itself, or post-chemotherapy, post-radiation, or post-surgical. We can also break down cancer pain into different modalities like somatic pain, visceral pain, and neuropathic pain. I'll give you some examples of these. Somatic pain is usually from tumor or mass effect. The cutaneous pain receptors are activated, and if the tumor is more superficial, like a chest wall pain, it will present primarily because of the mass effect it's causing on the mechanoreceptors and the cutaneous receptors. We see bone metastases or tumors affecting anywhere in the patient's musculoskeletal system, which can present as somatic pain. Patients describe this pain as primarily dull or sometimes sharp as well, but it's very nicely localized in their body because of the topographic presentation of the somatic fibers which carry the pain sensation. This is a classic picture of an AP view of sacrum, where you can see the mets. This patient had a breast cancer, and you can actually very clearly see the mets extending into the joint space in the right hip and pelvic region. There is a fracture of the right superior and inferior pubic rami and the ischial spine as well. So this type of metastatic lesion would primarily present as somatic pain. And the reason why it's important for us to understand these different presentations is because the management is going to differ, be it medications, be it our interventional stuff. The presentation of cancer pain will vary based on what type of presentation is happening, the somatic, visceral, or neuropathic presentation. As far as visceral pain is concerned, it's mostly due to infiltration, compression, extension, or stretching of the thoracic, abdominal, or pelvic viscera. It's primarily presented as pressure or deep sensation, sometimes spasmodic. It's not well localized. It's mostly referred pain, and it's sometimes hard to distinguish, where exactly this pain is coming from. And we have to do sometimes some diagnostic tests to delineate the presentation, and the management will depend on the response to these diagnostic blocks, as say. The next slide actually, if you can very clearly see, I'm not sure if you can see my cursor here or not. So there are colorectal cancer. This is a patient. This is a CT scan of a patient who has metastatic colorectal cancer with extensive liver mets. The left lobe of the liver is extensively involved with metastatic lesions, and this will primarily present as visceral pain. There will be extension of the capsule, and a lot of referred pain will be presented by this particular patient. When you talk about neuropathic pain as a presentation of cancer, it's a big challenge. It can arise anywhere in the nervous system. It can be central, your spinal cord can be involved, your peripheral nerves can be involved. Cancer can compress or infiltrate the nerves or nerve roots, or the nerves themselves can get damaged from cancer. Some common syndromes that you may see are cranial neuropathies, patients with skull-based metastatic lesions, or primary brain tumors can present as neuropathic pain. You can have a post-herpetic neuropathies. They are at high risk with immunosuppression with acute zoster infection, or recurrence of latent zoster. So always look at the skin when you're seeing a patient who's presenting with neuropathic symptoms in conjunction with a history of cancer. Brachial plexus neuropathies, some of the primary causes of neuropathic pain in breast and non-small cell lung cancer. Breast cancer seems to be the primary or the leading cause of brachial plexus neuropathies, secondary to infiltration, and after radiation, you can see, especially the brachial plexus, you can have involvement of lumbar plexus as well, but brachial plexus is highly susceptible to high-dose radiation causing brachial plexopathies. Some of the other common associated complications from radiation into that region can be post-radiation mucositis in head and neck cancers. For example, a young patient we're following with cervical cancer, post-radiation cystitis, overall seeing less, kind of very sophisticated and very advanced presentation of post-radiation mucositis in conjunction with horrible brachial plexopathy. In fact, we're actually, contemplating doing a complete neurolysis on this patient. Maybe I can keep you guys posted on the development of that patient. But moving forward, patient can have some chemotherapy-related neuropathies, especially related to cisplatin, Taxol, and alkaloids. They are well-known players. Patients usually have a symmetric polyneuropathy. It can be either axonal or demyelinating in nature, primarily demyelinating. But if a demyelinating lesion is really severe enough, it can cause a symmetric polyneuropathy of axonal nature as well. It's mostly localized in hands and feet. Some of the surgical neuropathies have distinct pain syndromes, like phantom limb pain. You see that primarily after amputation. The pathophysiology behind phantom limb pain is not well understood. So that makes management of that pain even more challenging. As far as post-mastectomy syndrome is concerned, it's a neuropathic pain in posterior arm, axilla, or anterior chest wall due to the interruption of the your primarily intercostal brachial nerve, which is the, I believe, a cutaneous sensory branch of T1 and T2. It's kind of a misnomer. You see this syndrome in women who have undergone radical mastectomy, lumpectomy, even just in like axillary node dissection. In about 5% of the patients who undergo any of these procedures will present as post-mastectomy syndrome, and at least 50% of them will have some kind of pain, be it neuropathic pain or somatic pain, associated with it. Next, this is a T1 weighted image, primarily showing metastatic lesions into the vertebral bodies, and you can clearly see an extension into the canal and cording. You can see the cord compression going on, and this will present as a very complex neuropathic picture, both below the level of the lesion and at the level of the lesion. And maybe we can talk about it later when we are talking about a few cases. So neuropathic pain, it is generally considered as a negative prognosticator when we are managing cancer pain. It tends to be non-responsive, and there are a lot of studies, there are a lot of data which supports that neuropathic pain tends to be opioid resistant. There's a conflicting evidence regarding this. Some people say that if you're using opioids, especially if you use opioids like methadone or fentanyl, which have a additional role in addition to acting on mu receptors, they have an NMDA receptor role. They can work preferably on neuropathic pain as well, but you will need higher doses for any meaningful reduction in pain. It's also associated with some cognitive failure in cancer patients. And cancer pain overall, I think it's such a complex scenario because of these different presentations. Generally, it's a mixed mechanism of pain, and rarely presenting as a pure neuropathic, visceral, or somatic pain syndromes, which make the management of this pain more challenging, because you need to distinguish what type of the presentations are there. And history is important, but sometimes you will require additional advanced diagnostic testing to delineate these presentations and manage them appropriately. This was a big study done by Dr. Portnoy from the Pain Management Center down in New York City. There was an international survey of cancer pain characteristics and syndromes, and this is pretty clear, and it kind of reiterates the fact which we have been talking about, that mostly the cancer will present as mixed pain syndrome. It will very rarely be an isolated somatic nociceptive, or very rarely be a visceral nociceptive presentation. So most commonly, it will be almost 50% of the patients, or 1 in 2 patients, will have some kind of a combination of these presentations, and thereby making our job even more harder to manage them. I will try to explain this conundrum with the help of a case report. So 50-year-old female with subacute onset of somatic, visceral, and neuropathic pelvic pain on history was recently diagnosed with stage 4 cervical cancer. She was admitted to the hospital because of intractable pain, and the length of stay was around 15 days, and she was still not able to report any significant improvement in her pain. In fact, if you look at her medications, I mean, you will be appalled. I mean, the the doses which you see here are just, out of this world. This is the first time I saw such high doses of opioids in a cancer patient. She was on methadone 50 milligrams 3 times a day. She was on neuromodulator gabapentin a total of 3,600 milligrams in 24 hours. And on top of that, she was on a dilaudid PCA. She was getting continuous infusion of 20 milligrams per hour and a bolus dose of 10 milligram every 10 minutes. And on top of that, she had a rescue dose available of 15 milligrams IV delivered by the nurses, in addition to another neuromodulator, duloxetine, 60 milligrams in 24 hours. So the medication she was on, I mean, she has probably saturated all the mu receptors available in her body, and she was still writhing in pain. And her presentation was a complex, mixed presentation, and we were actually at loss. We didn't know, whether it was, what percentage of it was somatic, and what percentage of it was visceral, and what percentage of it was neuropathic. So we basically started with some diagnostic blocks. We, we thought that, probably because it's a cervical cancer, then, hopefully there is a significant component of visceral pain coming on. So our rationale was to do a superior hypogastric plexus diagnostic block to see if she had, or how much of the percentage of the pain is coming from the superior hypogastric plexus. And we were quite hopeful that she would probably have a higher percentage of visceral involvement. So we actually did what we call a transdiscal approach to access the superior hypogastric plexus. If you look at if you try to understand the anatomy of superior hypogastric plexus, it's a small chain right in front of the L5 body. Now, there are multiple techniques which have been explained and devised in the literature to access that plexus. The most common and the most oldest technique is a bilateral approach along the L5 pedicles, and you try to get in front of the body from both sides, which is so challenging because of the lumbar lordosis. You're hardly able to get the whole plexus, and it's sometimes, because of the anatomy, it's so challenging to do a bilateral approach. That was I think explained way back in early 60s by Dr. Picotti. In fact, Dr. Kapoor, Dushyant's mom, it's my honor to be trained by her. She invented the anterior approach to access the superior hypogastric plexus. The approach which you see here, this is a AP view of an L5S1 interspace. This is a transdiscal approach, and this was invented by Japanese people, and have been extensively written about in the literature as well. And we just decided to do a transdiscal approach just for the heck of it. I was still a fellow, and I had done a lot of anterior approaches, and I just wanted to try and do a transdiscal approach to see if I can get a better response in this patient, especially with so much surgical scarring in the anterior wall, status post surgery and hysterectomy and other issues. So we were able to get really nice flow into the, as you can see, right in front of the L5 body. You can see the flow, the contrast flow. It lines up the superior hypogastric plexus really nicely. And we used our chlorprocaine and 0.5% bupivacaine. I believe we used 0.5% bupivacaine for this diagnostic block. And interestingly, patient only reported about 25% improvement in her pain, and we were really appalled to see very minimal improvement in her pain after the superior hypogastric plexus block, because we were anticipating a huge visceral component in her pain. Interestingly, when we saw this result, we we kind of proceeded to a diagnostic ilioinguinal iliohypogastric block, which was done under ultrasound guidance, and we again used 0.5% bupivacaine for this too. And patient reported like close to 40% improvement. She was a completely different person after this block. So the whole idea of presenting this case is to kind of reiterate the fact that cancer pain can be so mixed in presentation that you need your diagnostic blocks to determine what percentage of it is being modulated at what level. So finally, we actually proceeded with neurolysis of both superior hypogastric plexus and ilioinguinal and iliohypogastric nerves with 6%, I think 8% phenol. We used 8% phenol, and as you can see, patients' visual analog scores decreased from 9 out of 10 to 3 out of 10. Her opioid usage was significantly decreased. Her methadone decreased to 5 milligrams 3 times a day from I think it was 50 milligrams 3 times a day. A huge reduction. We were able to discharge this patient home in about 7 days' time. So this just tells us, the huge discrepancy between the presentations, and with a right type of diagnostic test and all these advanced techniques, you can really help these cancer patients with pain management and decrease the length of stay and increase their quality of life as well. So if you talk about principles of assessment of cancer pain, always history is the most important thing. Dispel the myths and misunderstandings. Often many of my patients don't tell me about worsening pain because they are afraid I will think they are an addict, which cannot be further from the truth. That's why, it's assess and reassess. As an outpatient, if you're starting something new, if you're starting a new pain medication, have a patient come and see you in about, a week or two, or call them after a week, a few days to see how the treatment is working. Don't start a pain medication and don't see them for about 2 months. You will miss all those windows of opportunities to act in that time frame. Use appropriate assessment techniques. The pain scale or faces don't work for everyone. Take function into account. Often elderly patients won't admit to pain, but may admit to discomfort, aching, or hurting. So, ask those questions to elderly population. Always try to include the family. Families, family members will be able to give a lot of insight into patients' psychosomatic and other biopsychosocial issues which are going on, and you can address those as well in formulating a comprehensive pain management plan for these patients. So always assess intensity of the pain, the relief, mood of the patient, and associated side effects of the medications. As far as the pharmacological management of cancer pain is concerned, WHO has a ladder which is widely accepted worldwide. The classes of medication ranges from non-opioids, adjuvants to opioids. As far as the WHO ladder is concerned. Okay, so I was basically talking about the pharmacological management in these cancer patients, and the WHO ladder is a very widely accepted, strategy to deal with cancer pain. As far as the different classes of medications are concerned, you can use non-opioids, adjuvants, and opioid medications. And if you look at the WHO ladder, if a patient is complaining of mild to moderate pain, the step 1 is to maximize or optimize their non-opioids like aspirin, non-steroidals, paracetamol, adjuvants like neuromodulators, gabapentin, Neurontin, and some other neuromodulators. If patient's pain is not controlled by these strategies, then don't waste any time to move up to the step 2, which is using or adding mild opioids. You can use oxycodone, hydrocodone at low doses. If even these strategies are not helping and patient is still complaining of intractable pain, then again, don't waste any time. Just advance to the step 3. Use potent opioids like morphine, hydromorphone. You can use fentanyl, methadone. But there's a new concept coming up. Dr. Timothy Deere from West Virginia, he has actually proposed to add another step, a 4th step into the WHO ladder, and which is the invasive treatments. Now, if you look at all the cancer patients and the data which is out there in managing cancer pain, if you stick with the WHO ladder, then about 80% of the patients you will be able to get good pain relief if you follow the ladder. And about 20% of the patients, these strategies will fail. So what about those 20%? So you have to make sure that their opioids have been titrated aggressively. You want to understand if their pain is neuropathic or not. Have a true pain assessment done by a specialist. Make sure that the schedule of the medication and the route of medication is appropriate, and the patient is taking the medication as prescribed to them. Once you have ruled out all these logistical issues and other associated issues with the medications, then definitely you should not be wasting any time before you move on to some of the really advanced and invasive procedures to manage this pain. Dr. Deere in 1999, he has been proposing this 4 steps since 1999, and I think most of the pain faculties are supporting him in his endeavor. And as far as the advanced cancer pain management options are concerned, they vary. They vary from different types of blocks to epidural steroid injections, intrathecal pain pump implantations, lidocaine infusions, ketamine infusions, sometimes even iatrogenic coma or sedation, neurolysis, be it peripheral neurolysis or intrathecal neurolysis, and spinal cord stimulation. These advanced procedures have become really kind of favorable, and most of the advanced cancer pain centers are jumping onto these interventions sooner rather than later to manage the cancer pain appropriately. Just to give you another case report really quickly, so 57-year-old male I saw with metastatic squamous cell carcinoma of tongue and larynx, with status post resection and radiation, was admitted for uncontrolled unilateral primarily somatic neck pain. So in this case, patient's history was primarily somatic pain. There were no descriptors suggestive of any visceral involvement or any neuropathic involvement. Again, the length of stay in the hospital was for about 10 days. We were consulted, and his medications were methadone, 30 milligrams, Q6 hours, and he was also on a hydromorphone PCA continuous and bolus doses. This is his picture. He has an open lesion in his larynx. That's status post radiation, and most of his pain was localized in the anterior triangle and over the clavicle, medial 1/3. And if you look at the anatomical distribution, we kind of thought of doing a deep cervical plexus neurolysis. So initially we did a diagnostic block with just 1/4% bupivacaine at C2, C3, C4 root. We did it actually bedside, blindly. I think I would, in the hindsight, I would recommend using an ultrasound guidance for this. You will be able to see the root, very nicely. But because of his, such thin musculature and his, I was actually, as soon as I palpated him, I was palpating his transverse processes, and I knew exactly where to go. So that was the only reason I proceeded with blind injection in him. But you know, moving forward, if I have to repeat this case, I would probably do it ultrasound guidance with a more controlled, in a more controlled setting, and you can really see the roots really nicely in under ultrasound. Just use a linear probe, a high frequency probe. You don't have to use a you know, the curved probe for this one. And we did a neurolysis with aqueous phenol 6% at C2, C3, C4 nerve root level. And the patient was able to wean his PCA off in 5 days, 75% reduction in opioid usage, 50% reduction in visual analog scores, and he was discharged home on just oral methadone and oxycodone. And this was the first successful deep cervical plexus neurolysis ever attempted in humans. I presented this case at APS conference, and you know, just got accepted in Pain Physician Journal. So really good outcomes with the neurolysis of plexus. If you do have patients with extensive vertebral body metastases involving lumbar spine, or even patients who have failed kyphoplasties, you know, there are new advanced blocks which are coming out. If you look at the anatomy, if you try to understand the anatomy of or the nerve supply of a vertebral body, you will see a significant portion of the pain is being carried by great MI communicants. Just to show you the exact location of the great MI communicants. So this is your body. This is your dorsal root ganglion. This is your dorsal spinal nerve root. If you can see my cursor, and this is the anterior nerve root. They both coalesce and form the spinal nerve here, and just anterior to the bodies of the lumbar vertebrae, you have your sympathetic chain, and right around here, this is where your great MI communicans is. So the whole concept behind great MI communicans block is that, you know, your vertebral body involvement might have a significant sympathetically mediated pain component. So if you do a diagnostic great MI communicans block, and if patient has significant improvement in their pain, you can actually proceed with a radiofrequency ablation of the great MI communicans. In fact, Chandler in 2001 reported 63% you know, success rate in pain reduction, and 42% you know, reduction in their analgesic usage after just great MI communicants block, and he didn't even proceed to the RFA. But it's a fairly simple procedure. Once you have a positive diagnostic block, and you basically use either, you can use chlorprocaine or 1/4% bupivacaine, or 2% lidocaine, or even 0.5% bupivacaine. If you want the block to last a little bit longer, you can add a very small dose of depomedrol, like 20 milligrams or 40 milligrams into the solution. And if patient has significant improvement in the pain, you can actually proceed with the RFA very safely in these patients. So the needle tip position is right at the posterior 1/3 of the vertebral body, and the approach is exactly as you're doing a lumbar sympathetic block. In a lumbar sympathetic block, your needle tip is right around here, anterior to the body, and you're trying to get the medicine right at the lumbar sympathetic chain. But in the great MI communicans block, your needle tip stops right at the posterior 1/3 of the body, and you can use a regular 10 centimeter RF probe to reach here and do the lesioning with classic accepted protocol, which is about 80 degrees centigrade, and you can do the lesion for about either 60 seconds or 90 seconds. If patients have significant upper extremity pain, secondary to involvement from the cancer, then one of the advanced procedure which you can perform is choroidotomy. And some of the indications of choroidotomy are unilateral pain below C4, C5 due to malignant disease. It's kind of relatively contraindicated in pain above C4, C5. If you have bilateral pain, then this advanced procedure is not for those patients. Axial pain does not tend to respond to choroidotomy. If you have compromised respiratory function, then definitely choroidotomy is not for these patients. The reason being, if you look at the neuroanatomy, some of the really important fibers which go into the respiratory function are just medial to the anterolateral spinothalamic tract, and while you're doing the choroidotomy, they're just millimeters apart. And if you have a patient who has respiratory compromise to begin with, and you knock off their fibers which are going to the respiratory center, then you have a really bad outcome at your hand. Thoracic choroidotomies are primarily done by neurosurgeons, but if you look at the literature, most of the cervical choroidotomies are performed percutaneously, either CT guided or fluoroscopically guided. And interestingly, I tell these to all my residents and my fellows as well. Radiologists are the smart people. They are the ones who actually are the pioneers in developing all these advanced procedures. And over the years, these procedures have been adapted by other specialties. If you look at even the history of interventional procedures, be it stents, be it cardiac stents, be it peripheral vascular stents, they all started in the labs and in the dungeons of interventional radiologists, and that's their artwork. And over the years, it has been kind of accepted by different specialists, such as be it cardiologists or physiatrists or other specialists. So the choroidotomy has been extensively studied and published, CT guided. Most of the literature is in the radiology world, and we are just adapting that and trying to do that percutaneously under fluoroscopic guidance. It's a pretty simple approach. You do a dural puncture at upper cervical region by a lateral approach, and as soon as you are in the intrathecal space, you instill some CSF that will line up your dentate ligament, and it will line up your ventral hemichord, giving you structural landmarks to advance your probes and your needles. You basically, basically use a stimulating and a lesioning electrode with 10 millimeter active tip to reach the anterolateral spinothalamic tracts, and in addition to the anterolateral spinothalamic tracts, there are spinal reticular tracts which you want to get by this lesioning as well, if you want good outcomes. As far as percutaneous choroidotomy is concerned, there is a good 75% success rate at 6 months and 40% at 1 year, established by multiple practitioners. And if you compare it with open surgical choroidotomy, the neurosurgeons are able to get 95% success rate at 3 months interval, and at the end of 1 year it drops down to about 55%. So if you compare these results, with percutaneous choroidotomy, you're able to attain still significant amount of or meaningful pain improvement in these patients with minimal side effects. As far as the metastatic lesions to the vertebral bodies are concerned, we talked about trying the great MI communicants block and RFA, but recently in the past 5 years, a a new novel approach of percutaneous radiofrequency ablation of actual lesions is becoming more popular. Unfortunately, it still doesn't have a CPT code to bill, but these are those patients who either are not candidates for radiotherapy, or they have maximized their radiation doses, or they have failed the radiation treatment to the spine, or there are recurrences where they're not candidates for surgery or radiation therapy. So it's a pretty standard approach for approach which you use for vertebroplasty or kyphoplasty. It's a transperpendicular approach. You enter the body through the pedicle, and you can see the needle kind of coming in. This is just I don't have the fluoroscopic images. I've not done this procedure in a human subject yet. I've done a couple of them at the training courses in cadavers, but we are in the process of bringing this new novel technique at Unity Hospital to offer this technique to our patients. And this can be done in conjunction with vertebroplasty if you have a compression fracture, in addition, secondary to bony involvement and metastatic lesions. This is again kind of an axial view. You can see the needle kind of coming in into the tumor mass, and you can do a radiofrequency ablation. Again, kind of the same picture. That's the probe, how it looks like. Again, limitations, as I suggested, there is no CPT code. There is no long-term data available from this procedure, and still no cost-effectiveness studies done for this procedure. So in the end, I'm not going to go into the details of intrathecal pain pump and spinal cord stimulation, because those are lectures in themselves. They're like, pretty extensive features. So I'm just gonna kind of try to conclude and see if you have any questions for me at this point. So just to kind of wrap it up, so cancer pain can be from cancer itself or from cancer-related treatments, can be somatic, visceral, or neuropathic. It's really important for you to understand the differences and delineate them in order to manage them appropriately. Negative effects of cancer-related pain can really affect the quality of life of these patients and can cause mortality as well. So you got to be really aggressive in managing and identifying these patients or these symptoms early on. And again, don't forget to take a good history, reassess. Choose a non-opioid adjuvant carefully, paying close attention to the side effect profile. If patients are unable to tolerate opioid medications, don't waste any time before you can move on to more advanced interventional procedures, or even an intrathecal drug delivery model through a cancer pain pump. Use the WHO ladder guidelines when titrating the pain medications, and use long-acting opioids for chronic cancer pain. Always recognize the fourth step in WHO ladder and utilize your multidisciplinary resources to appropriately manage these patients.
Okay.
And in the end, if you have any specific questions for me, would love to.
Dr. Kalia, thank you very much for that talk. One of the questions that I had during your talk was, and really these advanced procedures that I had really never heard of before your talk, including choroidotomy and the gray rami communicans block. Now, as far as indications for these procedures outside of cancer pain, to go outside of that realm with similar pathogenic mechanisms, say a vertebral body collapse secondary to osteoporosis, something that we see very, very commonly. Are you seeing, or is there data out there to suggest trials of these procedures in those conditions where there's pain associated with those conditions?
Yes, absolutely. In fact, vertebroplasty and kyphoplasty still remains the treatment of choice for compression fractures secondary to osteoporosis. But you see a lot of patients who are what we call like a failed kypho or failed vertebroplasty. They're still having primarily axial pain. That's the key word. The axial pain is the key word. If patient is still complaining of axial pain, status post kyphoplasty or vertebroplasty, then definitely go ahead with a diagnostic GRC block. If a patient has improvement in their pain, then you can very safely do a radiofrequency ablation.
Yeah, I think that's great, especially the 1-2 combination. It's from what I glean from the talk is my understanding really changed quite a bit when we make these diagnoses or we suggest diagnosis of cancer or metastatic lesions. We assume that they're going to cause one kind of symptom or sign. And what you clearly said, that it's very variable, a combination of somatic, visceral, and neuropathic pain, and oftentimes you have to go ahead with a particular type of, kind of almost a trial and error type of method, and try a diagnostic block before proceeding on to another step. And that's something that is very exciting and leaves a lot of potential as well. To that end, is there something in terms of the 4-step ladder that you alluded to? Is there a particular level where you, or a particular condition where you go into that 4-step quicker? Say with this patient, as you mentioned, with cervical cancer, or particular cancers such as pancreatic cancers, and I know their celiac plexus blocks are tried for those. Are there certain conditions that you come across to which you progress to that 4th stage, to that interventional stage more quicker than others, knowing that the first 3 will likely fail? Or do you give it a shot just because of the inherent variability within these cancer syndromes?
Yes, I definitely follow the WHO ladder. If you can manage the pain with medications primarily without any significant side effects, then looking at the overall cost of the system, both for the system and for the patient, I think it makes more rationale sense to try our different armamentarium of medications first. And but I have a very low threshold. I move from one step of the ladder to the next step very quickly. I see my patients on a weekly basis. All these cancer patients, I see them weekly, and I follow their pain scores, their response to the medications, and each step very closely. And I move from one step to the other, very aggressively. I have very low threshold for. I don't waste time stuck at a particular stage. You will see a lot of different approaches. A lot of physicians will try to optimize or maximize some of these medications like neuromodulators, but if you're not seeing any response in a decent time frame, then it doesn't make any sense to get stuck in that phase and try different other types. It's at the end of the day, it's a combination approach. It's a multi-modality approach to I would not use the word cure, but I would love to use the word curing cancer pain. I wish I could do that.
Well, one day, sounds like if we have as motivated and aggressive people as yourself, Dr. Kalia, that will be a reality. Yeah, for a patient population that's certainly very devoid of time, it's refreshing to hear that you're seeing these patients regularly and following up regularly. Most of the people who are on this call are going to be interventional radiologists in the future. I think it's as we move into that clinical realm, we can really take away a lot from your willingness to do that, and our willingness that we'll have to do that to embrace the patient population, to follow them up aggressively if we hope to help them and make real measurable gains. So I'll leave the floor open, and Joanna, I think maybe we can leave the floor open for a few more seconds if anyone has any other questions. Otherwise, we'll conclude.
Yep.
Okay, sounds good.
Hey, Dave here. Yeah, I think so. Sid. Hey, Sid. I just unmuted you. Do you have a question for Dr. Kalia?
Yeah, I was wondering, Dr. Kalia, if you could speak a little bit to the sort of response to interventional treatment as far as timeline goes. I know that people may respond very quickly to things like vertebroplasty and kyphoplasty, but other procedures might have a longer time course.
Mm-hmm.
what's the sort of patterns that you see as far as procedures such as frequency ablations and the different neurolysis that you perform?
Sure, that's a really good question. So once you do the diagnostic block, you know that you're in the right spot. You've delineated the different variations of pain, right? And once you choose your agent appropriately, for example, if you choose phenol, phenol has an added benefit that it will provide some analgesia instantaneously. So for about 24 to 36 hours after the procedure, phenol will provide some kind of analgesia. Now, the denaturing of the nerve and the proteins inside the nerve takes place over the course of 7 to 10 days, and the nerve degenerates in that time period. So I generally tell my patients that it would take about 7 to 10 days before they can start seeing any kind of meaningful change in their pain scores after a neurolysis. Now, on the other hand, if you use 100% alcohol as your denaturing agent, you can get the neurolysis effect much more quickly, in about 3 to 5 days. But on the other hand, the whole procedure itself can be a little bit more painful for the patients because 100% alcohol itself can be really irritating to the tissues and also the nerve itself. As far as the radiofrequency ablation is concerned, if you're doing a true ablation where you are denaturing the nerve itself and you're using 80 degrees Celsius for 90 seconds, there have been studies both in vivo and in vitro stating that the denaturation happens in 7 days. It starts by about 3 days, but in about 7 to 10 days, that nerve starts degenerating. Now, what's going to happen is the Valerian degeneration is going to kick in, and it's going to take about, based on the length of the nerve from its root, from its, how far along it's from the dorsal root ganglion or the spinal cord, or if you're talking about the peripheral nerve, how far along is that nerve, it's going to take that much amount of time for it to degenerate and start showing its full-blown potential. So that's why and nerves do regenerate as well. These procedures, when we do them, we kind of tell those patients. That's why we don't do these procedures in non-malignant pain, because nerves regenerate at a rate of 1 millimeter a day, and when they come back, they can come back really haywire, and you can have what we call a deafferentation syndrome post-procedure. It would take about good 2 to sometimes 12 months for that nerve to regenerate, but if it regenerates in a really weird manner, it can itself be a source of pain. We can safely do neurolysis in peripheral nerves and even big plexuses in non-malignant in malignant pain patients because of the severity of the disease and the severity of the symptom, and because it's kind of malignant. So,
well, I also think that does. Thank you for answering the question. I think that also brings up a couple of important things. One is the expectation management and really communicating with patients how long they can expect the pain relief or analgesia to take effect. Another thing that you brought up just near the end there, a lot of patients now are surviving for a lot longer than previously with the cancer diagnoses. Now they continue to say, well, survivorship has gotten so much higher, and we consider patients survivors now. How can you try to help these people who are living longer with their disease, continuously have controlled pain from the procedural standpoint? Because you yourself just kind of alluded to some of the problems that might happen down the line. Do you feel like people, after they have their pain under control via intervention, may be maintained on medications? Would it be easier to maintain them on medications, or what is your experience with that in general?
Yes, absolutely. So that's why we have been moving kind of away from neurolysis to radiofrequency ablation. We see a lot of post-afferentation pain syndrome as a side effect to neurolysis. But radiofrequency ablation, on the other hand, interestingly, doesn't cause that side effect. So if I'm anticipating a long survivor for a patient, if the cancer has been cured or is in remission, and I'm anticipating more than 2 or 3 years of survivorship on that patient, I would be leery in using neurolysis in that patient. I would be more inclined to use a radiofrequency ablation. If I'm anticipating, if patient is already on hospice, or if I'm anticipating less than a year of survivorship for that patient, then I'll be really aggressive. I can even put in phenol or 100% alcohol in the intrathecal space, doing intrathecal neurolysis as well. So it all depends upon what is the prognosis and what is the time frame we are looking at, and choosing our interventions appropriately. Now, when we do these interventions, most of the time we are able to bring down their dependence on high-dose opioids, and they are able to spend a lot of quality time with their patients without being sedated, without being under horrific side effects of these medications. In some cases, if patients are unable to tolerate the opioids, or if I'm anticipating a long survival in these patients, and I know that these patients will require, or their pain will get worse in future, and will require high-dose opioids, I will move really quickly to an intrathecal pain pump implantation, where I can deliver the medicine at 1/100th of a dose directly into the intrathecal space without any significant side effects, and I can maintain that really sophisticated drug delivery model for a long period of time, over years and years and years.
Thanks a lot for that response. I think that it kind of alluded to a couple of things that I was referring to regarding patient selection, and the microdosing for
Yes.
intrathecal pumps is just, I think, a very, at least in the few patients that I've seen, they've had very good experiences with it. So thanks so much for giving the talk. It was very informative and clear. So thanks a lot.
Oh, thank you. Thanks you. I was really amazed. I always tell all my colleagues that most of the the new advances come from the radiology world, and this is the first time I'm giving this webinar, and I'm really impressed. I'm really impressed by the technology, and how advanced you guys are in incorporating all these advancements in your teaching.
Well, we thank you. Sorry to cut you off there, Joanna, but we thank you so much, Dr. Kalia. You had residents from all over the country who had listened in, a couple of attendings as well. And again, we'll kind of close off after this a little bit. I will give one plug. August 6th, the Pain Management Service Line does have a journal club upcoming, and I was talking to Dr. Kalia before this presentation. There's a recent landmark article, an article that will become a landmark article that has just come out in regards to the cost-benefit and the efficacy of epidural steroid injections with regard to lumbar stenosis. Multi-center randomized trial all across the country. It's big buzz around the pain world, and certainly will be affecting reimbursements and will be affecting practice in pain management. That, amongst two other articles, will be discussed on August 6th. You'll be receiving emails, so I do encourage anyone who can make it to please make it. And I hope you enjoyed this as much as I did. I certainly thank Dr. Kalia for an amazing talk. Really appreciate your insight, your enthusiasm, and we can we can hope to learn a lot from that. So thank you, Dr. Kalia.
Thank you.
Thank you very much, Dr. Kalia. Thank you, Dashant, too, for inviting Dr. Kalia to speak with us tonight. So everybody out there, if you would like to watch this presentation again, it was recorded, and we will post it on our YouTube channel, IR Webinar. And have a good night, everybody. And thank you very much again to Dr. Kalia and Dashant.
Thank you for having me.